welcome each one of you. And today there will be a case presentation of capillary hemangioma of the middle ear. The speaker is Dr. Abhinava Ghosh, and moderator is Dr. Kesavananda Kumar. He is a very dynamic ENT surgeon, and his major field of interest is in endoscopic skull-base surgery, endoscopic nose and ear surgery, and laryngotracheal disorder, and head and neck surgeries. Over to you, Dr. Keshav.
Thank you, Vandana ma'am. It's been a very long time that Pratiksha Academics has been going on, and it's good to be associated with it. And thank you for inviting me to moderate this session. So today, as we know that Dr. Abhinav, he is the speaker. He'll be going to speak on capillary hemangioma of middle ear. So before going to the topic, I would just like to introduce him. Dr. Abhinav Ghosh is a very dynamic young surgeon, ENT surgeon. He completed his MBBS and MS from Silchar Medical College. Then he was under Dr. Satish Jain, where he did 2 years of work under him, and he got his training, extra training in various fields. And now presently he is working. He has in Chikitsa Clinic. He has owned his OPD, and so I will just hand over to Abhinav so that before going, Abhinav. Yeah, you can just start with the topic. We will not take much time.
Thank you, Keshavda. I'll just share the screen. Yeah. Today I'll be presenting on very uncommon case, which is the hemangioma arising from the middle ear. The patient is Monica Minj, who is a 55-year-old elderly female residing in Nalbari. She presented with blocking.
Abhinav.
Yeah.
Just before, I'm sorry to interfere in between, but I think you should not have mentioned the name of the patient.
Okay.
Because I think this is not ethical to
sure.
highlight. Okay. Yeah, please.
So our patient is a female, elderly female of 55 years from Nalbari, and she presented to Barua Nursing Home to Dr. Rohan Barua with blocking sensation of the blocking sensation in the right ear. She also complained of slight decrease in hearing from the right ear from 1 year back, slowly increasing till we had examined her. She complains of ringing sensation in the right ear since last 6 to 8 months. However, from the last 1 month, she has been complaining of blood-stained whitish pus discharge and pain from the right ear. On examination, we found there is a mass which is brownish and slightly firm, not too firm, not cystic, but slightly firm with a dark reddish hue. There was blood-stained purulent discharge emanating from the sides of the mass, and the mass was present at just the opening of the external auditory canal. The mass did not extend beyond the meatus into the concha, and the auricle was normal. So neither the endoscope nor the probe could be maneuvered beyond the mass due to the absence of any space. When we got the patient, we just suctioned the discharge and the blood and from around the mass, because we could not go inside and we could not ascertain how deep the mass was or from where it was coming. So after suctioning out, the fresh blood came out, which was readily controlled within a few seconds. There was no significant past family or personal history. On otoscopy or autoendoscopy, as we said, it's a brownish mass with a reddish hue, and there was blood-stained purulent discharge all over the sides and all over the mass itself. There, while suctioning, we did not find the mass to be friable at all. However, it used to bleed on touch, especially the sides of the mass, where which we thought that is mostly due to the excoriated skin of the external auditory canal and some granulation also. Till now, it's all pointing towards a case of chronic otitis media. We are seeing polypoidal or granulomatous mass in the external auditory canal with complaints of discharge and hearing loss. And the first thing which usually comes to our mind is a case of chronic otitis media, which with polyp or infected granuloma type of lesion coming from the external auditory canal or from the middle ear through the tympanic membrane. Since this was, we did not know whether this mass was coming out from the external auditory canal or the tympanic membrane, so we decided to go in for a, just a second, I think so. We decided to go in for a HRCT temporal bone to better guide us for the treatment. On HRCT, we saw a soft tissue density filling the entire right middle ear cavity. The mastoids were sclerosed, and but the soft tissue density was extending from the right middle ear up to the editus antrum and extending all the way up to the external auditory meatus, completely filling up the external auditory canal. The mastoids were sclerosed, however, it was filled with soft tissue density, which probably we thought maybe is just the pus which has been accumulated due to the long-term disease. The lesion involved the sinus tympani, facial recess, oval round window niches, and the anterior epitympanic recess. Ossicular chain was intact, surprisingly. The TM could not be appreciated at all. The facial canal is intact, the sputum is intact and not eroded, which again is suspicious, because in such a disease we think that there may be a chance of cholesteatoma along with the disease, but the sputum is intact. But in cholesteatoma, the most pertinent feature is that the sputum is eroded, especially in attic disease. Inner ear structures are all within normal limits. Major vessels like the jugular bulb, carotid canal all appear to be in their normal bony outline. Sinus plate and tegment tympani are also intact. On tuning fork test, we found the Weber to lateralize to the right. The Renes was negative on the right side, like the BC was more than the AC. On the left side, it was slightly better, however, not completely normal. Here is the audiogram we can see here. Tympanometry was not done because the probe could not be inserted as the ear canal was completely closed. The patient was taken up for surgery after 1 week of IV antibiotics. Preoperative biopsy was not done as the investigation and findings did not raise the suspicion enough to get a pre-op biopsy. There was no otorrhea when the patient was taken up for surgery at Porva Nursing Home, Nalbari. Just stop sharing. Should I stop sharing, or the video can play directly? I think so. I'll stop sharing. And
you have to stop share.
Yeah. Okay. So before I start, I would like to just say that since I have mentioned twice or thrice already that we were not expecting such a case, even after looking at the CT scan and the otoscopy and endoscopy findings. So we did not have the recording on for the video. So once we had gone in and started we had made the post-oral incision, we had gone in and taken a big chunk out of the mass so as to send it for biopsy. And then this is the picture we get. As soon as we took out we put some cuts into the mass for taking the biopsy, this is what happened. It's continuously bleeding like anything. So we tried to control it with a bit of bipolar cautery, but as you can see that it is of no use. It will keep on bleeding. The whole mass is completely composed of vessels and it's bleeding. So right now, at this stage, we stopped the surgery. We went back in. We told the anesthetist to take the patient under general anesthesia, as we were doing under local anesthesia. And then we started to study the CT scan again. Even after studying the CT scan, we could not find anything which would suggest that this might be something else. So as you can see, we are struggling with this, and as we are struggling, we decided to take some more pieces of the tissue for biopsy, and then we just pack the canal with the gauze, and we start with the mastoid work. Because what our thinking behind opening up the mastoid and not just to go transcanally was because that since there was soft tissue density within the mastoid also, we were thinking that maybe whatever this mass was, whether it is a glomus, a large glomus, or a hemangioma or whatever, it could be extending into the mastoids, and that way once we open up the mastoid we can get a better picture or better view and then decide our next plan of action. So as we entered the antrum, we can see that there is no mass. We could only find some secretions which we had suctioned out, and the mastoid is completely clear. We can also see the incus from here, and we have drilled all the way down, but we still cannot see the mass. So now this was posing another challenge, and we went in. The whole field was very bloody, by the way, because as we would probably understand by later on that this was a hemangioma case, and there was proliferated vessels everywhere nearby. So here what we decide is we should go in and pull the canal wall down. And the thinking behind that was that we should get the maximum space to work and get all around the tumor, rather than just cauterizing here and there. We should get around the tumor and try to cauterize it in the base so that it doesn't recur or anything like that. So we turned the case into a canal wall down. Here we're taking the last part off, and as you can see, the whole of the operation is completely bloody. Now we can see that this part, there is some part of the tumor which is above the incus. We are trying to separate the incus. First of all, we thought that we will try to keep the ossicles, since the ossicles are intact, but then we just left all hopes of keeping the ossicular chain intact, and we thought that maybe if later on we can get the case, we will do a second stage hearing preservation surgery. So we can see the malleus here, and this is the area. This is the area of the facial, and this is the area of the stapes. We are trying to find out where the mass is arising from. Just gentle dissection with this is a sped up video, so it might not look so gentle, but at least it's sped up 2 times. So now we can see that there is no attachment towards the mass near the eustachian tube area or in the epitympanic area. So we tried and start our dissection from there. I'm trying to pull as much as possible. I'm trying to provide traction with the suction, as I cannot hold it and it's very friable. And with the repositor, I am pushing it downwards so that I can see the margins. Here we have again started to use the bipolar cautery. I was a bit skeptical of using the bipolar cautery, although I should have used it a bit more, because then I was feeling that I would lose the main vessels which was feeding it. So, but still, we see that we found that the most of the attachment was in the hypotympanic and the protympanic area. So we started to cauterize this area with a bipolar cautery. Yeah, see, this area is completely clear. There is no attachment whatsoever. So probably this hemangioma was arising from the tympanic plexus or something, because and here you can see I'm using the bipolar as well to pull out as much as possible, and then we cauterize the base. You can see the mass here. The bleeding showed no signs of stopping, and we could not reach till the end of the tumor even after using bipolar cautery in the hypotympanum. So we decided to drill more. We decided to drill more and drill up to the bony sulcus and then go under it. Here we can see we have drilled up to the bony sulcus, and the 12th suction is helping us to keep the bleeding in check, as I have put the suction just over the bleeding vessels. Here you can see the tympanic annulus. I'm using the sickle just to rid the mucosal bandings between the mass and the undersurface of the tympanic annulus. Here we can see it's continuously bleeding again and again. On a higher magnification, we can see the spurter. It's a very the vessels spurted so much that even through the ear it came up to the mask, despite I was so far away, like through the even beyond the microscope. So here again we are trying our best to get the bleeding under control, but once we cauterize one vessel, another bursts and starts bleeding. So again, we had to follow the same principles that I try to go beyond the margins as much as possible and expose as much as possible. Then only we'll be able to get the bleeding under control and the tumor removal will be successful. So here we are working in the at around 4 o'clock area, and this is where the largest vessel of this whole tumor was located. Some sort of control we have achieved after cauterizing this large vessel. Further drilling, this time we are using a diamond burr so as to not hurt the or injure the facial nerve, and despite our best efforts, we had created a small rent over the facial. However, we'll show that later on. Here we can see that the vessels near the stapes footplate were bleeding like anything. They were spurting, and this is the last remnant of the tumor which is left, and we will just cauterize that and try to remove it as much as possible. With the diamond burr, after cauterization, we have tried to with the diamond burr, we have tried to drill out the bony crevices of the middle ear near the round window. We are actually not supposed to use cautery around the round and oval windows and all, but this case was such that it necessitated such actions. But we were not worried about the hearing status of the patient, as we had to, but still we got a good hearing. We did not have any sensorineural hearing loss even after cauterization near the round window. Here we can see the last ends of the surgery. Not end, but we are at the last ends of the cauterization. Bipolar cautery was used throughout, but this one we used the suction and some amount of unipolar cautery, as the bipolar was not reaching there, and we were not ready with a smaller bipolar. Here, what it looks very vigorous, but it is sped up. I'm saying again, but this is where we were trying to destroy the trabeculae, and so that the vessels which were hiding inside the trabeculae of the bones, they expose themselves and we can cauterize them. Here is the round window. After looking at all the areas, the main we had come to the conclusion that the tumor has arisen from the inferior and the anterior-inferior portion of the ear, and mainly from the protympanic area, and also from the hypotympanum. There were few remnants in the left behind, which we are drilling again and again and trying to expose. As you can see here, there is a small rent over the facial canal, and the facial has been exposed here. Overall, this was the last major spurter which we had to deal with, and very near the round window. So we were a bit skeptical, but needs must, we couldn't help it, and we had to cauterize there. As you can see, it's spurting like anything. And the last cauterization will help. Sorry. So this is the end product, and I mean that all the ossicles have been removed and all the tumor has been removed. Slight bleeding from around the bony trabecula in the middle ear. So we just use some gel foam to deal with that bleed. This one is all about exposure and cauterization. There is not much else to do in this case, because wherever here we ended this case with lots of gel foam all over the from whichever all the areas which were exposed due to cauterization, and we did not do any ossiculoplasty, cartilage ossiculoplasty, with the fear that the cartilage might slip and which may cause the dislodgement of some clot or anything. So we just left it, and we will visit it later on if the patient wants some hearing improvement. So we just like a normal canal wall down, we are placing the temporalis fascia graft, and we will finish it with some split thickness skin grafts, as there is no tympanomeatal flap, and without the tympanomeatal flap, if we place only the graft, then this will weep for months or maybe even years. So in this kind of case where there is no skin, we usually go for split thickness skin grafts. Yeah, we've placed the TM directly over the middle ear, and just with lots of gel foam in between. And there is we had actually performed facial nerve decompression also, which I have excluded from this video because it's not under the same heading. So after the facial nerve decompression, we just put the split thickness skin grafts and the temporalis fascia. And especially in this case, we usually like to put a piece of skin over around or just over where the facial nerve will be. It will give us slightly more strength, and that area will not be disturbed too much, hopefully. So this is what we did. Yeah, we are just closing up with the gel foam, and that's it. I will just go back to the slide. So this is what we could see. This is the histology. We send the biopsies for the, we send the just a second, I cannot see this. This is the black bar. Can I remove this black bar? How can I remove this black bar?
Just right. Abhinav.
Sir.
Just click over the bar and right click over the bar. Right click over. Hide the floating bar. Hide the floating bar. Right click over the bar, black bar.
Okay, thank you. So on histopathological examinations, these are the ones we have obtained from the pathologist. The sections show polypoidal piece of squamous lined tissue with surface ulceration and slough. Subepithelial connective tissue shows abundant proliferation of capillary-sized blood vessels along with mixed inflammatory cells or infiltrate, which is suggestive of capillary hemangioma. Till now, there are around there are very few cases of reported of capillary hemangioma, especially, and maximum of these which have been reported are not huge ones which are presenting in the external auditory canal, but which are just over the tympanic membrane or arising from the external auditory canal. And this I think so in literature, if we see, this should be the 23rd case of capillary hemangioma of the middle ear, which has gone into the, which has extended up to the external auditory canal. So I think so this is my short presentation. It was just about the surgery and the case which we are talking about. So if we can go for anything else if you want. This is the patient. Keshavda told me not to show the picture. I'll not show it anymore. So this is the patient, just to show that the facial is all right post-operatively. And there has been 23 cases of capillary hemangioma according to PubMed, according to the searches in PubMed, and 17 cases of capillary hemangioma. And because some of these contain cavernous hemangioma as well. And IHC sadly could not be done, and we are following up with the pathologist to get somehow to get the IHC done, which will prove this case to be capillary hemangioma rather than leaving it to the pathologist who will, who according to whose diagnosis we have to go. Immunohistochemical staining has to be positive for CD34, 31, FMA, VIM, and SMA, and negative for S100, EMA, CD68 to call it a capillary hemangioma. So I wanted to present this case because I thought that this is a very this will provoke some discussion, as it is it presents as a very innocuous case of chronic otitis media, which we all do routinely. However, it has caused a quite a bit of problem for us during the surgery, and we were slightly underprepared, and we had to make things up as we went. So this is where I would like to end. Thank you.
Thank you, Avinav. It's a really interesting and very nice presentation, and a very good surgical demonstration. Means the thing is, I personally have not found any capillary hemangioma, because as it said, it's a very rare finding. And I personally encountered 2 cases of middle ear masses, basically vascular masses. So which one came out to be a glomus tympanicum, and other one came out to be schwannoma. But so that was on histological diagnosis only.
Yes.
And both the cases we did it in when I was in Delhi, and interestingly, both the cases were from Assam only.
Oh.
So
even
yeah.
Until the histopathological results came out, we were expecting it to be a glomus tumor, because we had no idea that capillary hemangioma occurs in such a large thing in the ear. So
it's a very rare thing. It's only histopathology. Only after the histology comes out, then only you get to know that this is there is something called capillary hemangioma.
Yes.
Otherwise, you can think of an hemangioma or any AV malformations in the middle ear. Yeah. As per the literature, there are site predilections, like 3 common sites which has been mentioned in the literature. Is the geniculate ganglion, then your origin near the chorda tympani,
near the nerves.
And your case was typically, if you see the origin, that is the it was more into the hypotympanum.
Yes. Hypo and pro, maybe. Yeah.
Lower pro. Yeah. Yeah. So I think there is not much questions from the audience. Anyone would like to comment anything?
There is one question.
There's one question.
Is there any question? Okay. This question from Ashish, that whether arteriography was done in this case to check for vascular blush.
No, actually nothing was done. No fancy tests were done, because we didn't even know that this is a case of capillary hemangioma.
Yes. Usually what happens means, as I told, that even the glomus tympanicum case also, it was on the suspicion. It was not even on suspicion that it came out to be on table. We diagnosed it to be the glomus tympanicum. We just did a simple, CT scan, and CT scan there showed there is a mass.
Yeah.
And it was not. It looked like a vascular mass. It's like an angry-looking polyp only, and nothing else. But on table, when we just opened it up, it started looking like anything. So more or less, these kind of tests usually, I think, and so it goes on in very highly, if there are some kind of extension noted, or if there is some bony erosion is there,
Yes.
Extension beyond the middle ear is there, then I think one may go for a
Yes.
arteriography or any other such contrast studies. Otherwise, usually a simple middle ear mass, you may not tend to end up doing all those things.
Yes. Very true.
Can I ask you a question? Yeah. Can I come in?
Yeah, because please.
So yeah. Yeah. So thing is that like post-operatively any CT scan of the brain was done just to rule out any intracranial
Actually, no, sir.
Yeah.
Yet again, we are not first and foremost. We have in the intraoperatively itself, we did not find any kind of tissue or extension which would suggest that there may be some kind of intracranial extension. And also in the CT scan, HRCT, which we had, and there is nothing to suggest that there is no bony erosion anywhere. So
Abhinav, I'm not asking about intracranial extension, and there is some 10 to 12% coincidence of a middle ear arteriovascular malformation with intracranial malformation.
yes. Some
syndromic,
syndromic.
like from that side. Yeah.
Okay, no, sir, it was not.
So, what was your pre-operative diagnosis? Like when you started, what you thought, like clinically?
Sir, we took this case as a chronic otitis media with a polyp. Normally, when I get a case with a discharging ear or bloodstained discharge with a polyp, what we usually do is we just give antibiotics and wait for some time. And sometimes, if it is just an ESC polyp, it usually regresses. And so this case, what we did was we went for IV antibiotics because this patient was quite discharging quite a lot and with bleeding. So we thought the bleeding must be from the granulation nearby, and also the skin must be excoriated like anything since it is discharging. Also, the tinnitus, what we usually see is we find tinnitus in normal otitis media cases as well, because there is the pressure of the pulse, and the patient always says that there is some kind of dhub happening inside the ear. So we take that, we use whenever the patient says tinnitus and presents like this, we think that okay, it's that kind of tinnitus because of the pulse and all. And then my diagnosis was that it is a case of chronic otitis media with a polyp, which has most probably arisen from the middle ear and is most probably mucosal granulation and all these things mixed together in a polyp. That's it. And we will get some disease.
It's really a very interesting case, Abhinav, and case of like you have said, like 25 cases been reported. So it's a very interesting case because capillary hemangioma usually we see in the pediatric age group. Like
yes.
It happens in a pediatric age group. And you have mentioned that this is an elderly lady. So it's an interesting case. Thank you, Abhinav. Yeah, thank you.
Thank you, sir.
So because just I'm asking you, because so do you think then he should go for CCT brain or any further test now?
Was because I had an experience like that. One they say it came out to be a cavernous hemangioma in the external auditory canal. So we removed it when I was working in Joy. So eventually that patient had a seizure after 6 months. So when we did a CT scan, there was one more hemangioma in some brain somewhere. I forgot. So that's why I was asking like whether a CT brain or not.
I think so that we should go for a CT brain now because that didn't.
chances are very less. I think it's less than 10%, but still, yeah.
Yeah.
Yes, so,
No, but still we.
Yeah.
Can I? It's an excellent presentation by Abhinav. It's a commendable job. It's not easy task to do surgery like what you have demonstrated. But definitely after your presentation, I'll definitely ask if this kind of bleeding mass. I'll ask few radiologists. We are very specific about few radiologists in Guwahati actually. I'm very personally, I'm telling you. And definitely I'll ask them, should I go for a little bit of contrast study or any arteriograph or angiogram for this kind of scenario? And definitely if you meet a position that if it is required, then definitely I'll go for it the next time. Because what this surgery you have performed here, it's excellent, I can say. And because you know the anatomy, you see there is a dehiscent facial also. And you every time you have your only equipment is a bipolar, no instrument is there. So in that kind of scenario, knowing all this anatomy, not only the vascular things and also the other important structure like mostly the facial, you are not bothered about the hearing because it's also you are not concerned about the ossicular status and all these things, but definitely facial dehiscence and all other vascular structure around that the middle cleft along with your, as because has says, up to the intracranial extension or any kind of communication, that picture I'll from the next time onwards I'll want to know the details. That's my add-on to your presentation.
Yes.
Great job, Abhinav.
Agree with Biswa, like it's a commendable surgery, like the bleeding. If you can see, like throughout the surgery, many of us would have just packed and come out, like but continue to the surgery, and it's a excellent job, I think. Yeah.
And particularly bleeding from your both the oval window and the round window. Yeah. It's difficult. It's really.
I think this is when we see say during examination also the mass bled. I think he mentioned that during OPD examination. So in these cases, like if we just give a little bit of contrast and we know the character of the mass, like
because
exactly. True, very true.
And most important is for the juniors actually. I don't know that we should not go for any kind of biopsy, because suppose if you think CSM with some granular tissue in this kind of scenario, you should not go for any kind of biopsy, any kind of pans in a OPD setup. If it is an OR setup, it's okay. You can pack the patient, but sometimes it's maybe face a kind of very difficult scenario. If you go for a pans biopsy in an OPD setup, so don't take any kind of biopsy.
But I think in this case also biopsy, even if supposing it's kind of a polyp only, but biopsy would have been indicated. I personally don't unless and until means so you
can take the biopsy if you want to histopate beforehand, little bit of idea, but with all precautions in this case the background of the bleeding polyphus, because according to the history he has many episode of.
But ideally, for any vascular mass, there is no need to go for a biopsy. Exactly. But even though if I'm not thinking of even if it is a vascular also, even if I'm thinking it's a normal supposing up on CSM with granulation, then also I don't think many of us will say that we go for a biopsy. Most of the time we don't go for biopsy. Whatever biopsy we do is a post-op biopsy.
Yeah.
Yes.
So one more question is there. Okay. Sanchita, how long have you followed up the patient till date?
The patient has been followed up at least twice after the surgery. Dr. Rohan has been following up. I think so.
Twice means it's like a month or?
No, one is just 1 week after the surgery, and one more is 15 days after the first visit. So we have
almost 2 to 3 weeks.
Yeah, the patient is perfectly fine, no tinnitus, and she's actually very happy without hearing. So I don't think so. She will be going with a second loop
Mainly,
surgery.
she must have been relieved with the heaviness and tinnitus.
Heaviness and discharge and all these things.
Okay,
And
and one more
congrats-
question: role of CO2.
So CO2 is whoever has it is can do it. Peshabda can do it. Can do it. Laser is very good, but we had to work with such a big, bulky bipolar cautery. But laser would have been amazing.
Yeah, definitely. But for that means if you have all the equipments in standby, that then you can tackle anything.
Yes,
any
yes,
case.
that's very true.
But you did a very good, commendable job. With,
Also, congratulations to your co-pilot, Rohan.
Yes, Rohan.
Because it's this kind of scenario, if your co-pilot is not good.
No, and the thing is that since it is Rohan's case, I have to take a little bit of less mental burden and just focus on the surgery, and he can take as much attention as he wants. So that is also one more thing. If you are doing someone else's surgery, you are slightly more cool and you can make better decisions, I think, sometimes.
Great.
Okay. Can I comment one or two things?
Sir,
sure, sir.
Abhinav has done a commendable job in a setup in Nalbari, particularly, not at Guwahati. That is the first one thing. And both of you is under training from Satish. Therefore, I think you dare to continue the surgery, as it is difficult. But I've seen done, I've got only one glomus tympanicus long back, but with packing and something with gauze. At that time, there was no bipolar also. Just with gauze, I can remove it, but ultimately bleeding is controlled. But I want to ask you, in Silchar Medical College, there's one case of doing master, there's severe bleeding. Ultimately, this case was put in a workshop in Nabaikon, in Silchar Medical College. Mohan Kameswaran was there. He has done the surgery, but very much bleeding. What the case came out? Do you know, Vinap, at that time you were there in Silchar Medical College?
Sir, I don't think so. I was there. Because when I was PG there, Mohan Kameswaram sir did not come once also.
So it is in 2008.
So
2008.
4 years before I entered PG, sir.
I was the first year PG that time.
2008, I think later part. Okay, but first diagnosis is always the glomus tympanicus, and only the bipolar is the solution. But if you suspect also, no, if you suspect, you can, I think, done an MR angiogram also, where you get the feeding vessels. And other thing is that, what do you, academically, what do you think the artery is responsible for here? Bleeding? Without doing the MR angiogram, what artery branch is responsible? And what is the site of origin you think, like your glomus?
Sir, this is a hemangioma. So this will, I think so, the hemangioma usually, especially if it occurs in such an elderly person, it will require some nidus to cause the angiogenesis. So what I think is that maybe it has arisen from the tympanic plexus, as it is as we can see after the cauterization, all of the lower part of the tympanic cavity was cauterized, and that is the area of the tympanic plexus, and the nidus must have been some infection, which long-standing infection, which has caused the proliferation of the vessels.
You are correct in a sense. This is the impure tympanic artery, called the plexus in the hypotympanum and the promontory, like your glomus. Glomus is responsible for this impure tympanic artery. That question was asked in quiz also. I think you forgot. And for the glomus.
Abhinav.
Yes, sir.
You have searched the literature now. If there is any rule of beta blocker pre-op in this kind of scenario?
Yes, that we can start.
In the literature,
I don't know actually. That's fine.
Yes.
In the literature regarding hemangioma in the middle ear, there is nothing called. There is nothing for propranolol or beta blocker. But as a whole, beta blocker is the first primary treatment of choice in hemangiomas, because it reduces the it has a early, intermediate, and long-term kind of actions. So it will cause vasoconstriction, it will cause inhibition of angiogenesis, and that will decrease the size of the hemangioma. And in some cases, even they say that propranolol even causes apoptosis of the hemangioma endothelial cells. So it is a fantastic drug for hemangioma, but I have not found any literature. Any of the literature, I have searched all the 23. I have one was in some other language. That one I didn't know. Otherwise, there was no mention of propranolol, because almost all the cases, whichever was not very evident, like those above the TM, and we can visualize that there is something moving and there is some kind of bleeding mass. And other than that, every case was that they thought something else and they went in and they found this.
I think in a pediatric group, it is more working.
Yeah, I know, sir. Pediatric groups, there's excellent result, excellent outcome.
Yeah, excellent result.
Pre-op also, if you can give propranolol for weeks or 10 days, then I don't know how it helps.
It mentioned in the book that pediatric group, it works best.
Yeah, sir. We have a good experience.
Pediatric group, because capillary hemangiomas are more common in pediatric group.
Yes.
Adult, very few reported cases.
No, because of what I am saying, suppose pre-op, if you can give a pre-op.
But if we have a pre-operative diagnosis,
inter-of bleeding and all these things.
This all 25 cases, these are all like post-operative histopathology. So I think if we know pre-operatively, maybe we can try and reduce the vascularity. Otherwise,
it's difficult. Yeah.
Yes, Sanjita. The history was about 6 to 8 months, I think so. Yeah. She had heaviness and block sensation in the ear. The whole history is about 1 year long. Yeah. The complaint started 1 year back, and as we can all agree that only when the symptoms become a bit severe, then only people start noticing. So I don't think so it should be like exactly 1 year. It may be more, but she started noticing her block sensation and all from last 1 year.
So I think there are no much further questions. We can conclude the session, Anjana madam.
Yes.